My sincere thanks to Srinath sir and Karthik and Sriram. My topic is limited to dysphagia in laryngectomy patients. Last year we done a tribute to Bilram doing 150th year of laryngectomy. We did a 2-day conference in Kidwai. Dr. Anil Cruz sir and so many people have attended. Our department, a few years back, we were doing only the laryngectomies and neck dissections. Maybe that is the reason why we were doing a lot of laryngectomies in India. Last 6 years, oral department has been merged with our department. Now, bulk of the oral procedures are oral cancers. So, going to total laryngectomy, as a surgeon, I always counsel the patients for laryngectomy in the T3 or T4 stages. Because in Kidwai, earlier the chemoradiotherapy was not freely available. So patients are coming from a rural background. They were not able to stay in the hospital for 2 or 3 months. And chemoradiotherapy complications, if I explain, so they were agreed to the laryngectomy only. So that is the reason. Nowadays, because of the processes available, so speech is only the problem. Then you can give a speech with the processes, and you can do a total laryngectomy and whatever, depending upon the post-op, we can give adjuvant treatment. So the indications, as everybody knows, the advanced laryngeal and nasopharyngeal malignancy, T4 tumors, any failed chemoradiotherapy salvage setting, and in the dysfunctional larynx, maybe the older thought was to remove the malignancy. Now the present situation, we have to give adequate functional outcomes of swallowing and speech to provide optimal quality of life after laryngectomy. So what happens after total laryngectomy? So we remove the specimen. So this is where it affects the swallowing. When you remove depending upon the stage, say for example, hypopharyngeal malignancy involving the lateral pharyngeal wall, or it is going towards the posterior area, or if it is extending towards the oropharynx, so your resection will be more. So you are removing the inferior constrictor muscles as well as the all infrared muscles you are removing, and you left with only the opposite side. Okay, so we try to avoid earlier doing PMMC patch pharyngoplasties because of the leak. It will be very long. Hospital stay will be very long. Those are the cases. That's why we used to try to do primary closure. So when we will do primary closure, the minimum adequate margin of 2.5 centimeter or stretched 3.5 centimeter. If it is available, we try to do a closure, primary closure, either in the T-shaped closure or vertical closure, or sometimes adjustment. You bring some mucosa from opposite side and close it, rather than doing a PMMC. Those are the concept we were having earlier. Now, because of the oral cancer cases have come, now every day we do in a week 50 to around 50 PMMCs we are doing. Now we are very confident of doing PMMCs. We have to accept it. And second one is free flaps. Not available in Kidwai. It's a high volume center. You have to finish the laryngectomy in 3 hours so that you can take one more case. So that is the reason. So we try to avoid doing free flaps. We try to avoid all these reconstructions. So horizontal vertical closures without using the constrictor muscles will be better rather than doing only prime mucosa to mucosa. This alter the physiology of the swallowing, leading to several changes in physical, emotional, and social aspect of the patient. So how the patient will? Now what happens once you do a laryngectomy? My first priority is after 9th day or 10th day, I'll give a test feed. If there is no leak, what we give? Only water. So water you'll swallow. There is no leak, I'm happy. Remove the sutures, send him home, come after 15 days or 1 week, 1 month, send him to radiotherapy. That's all, that's where my work stops. Because we do not have speech and swallowing SLP people in my department. Almost for 15 years it was not there. So recently after I became HOD, I request some of the speech and swallowing institutes, come and work here, bring your students, learn. So many people are coming honorarily, some are working on ad hoc basis. So now we are encouraging the department to develop speech and swallowing in my department. So how the patients will come to us after they go home, they'll come and tell, food is sticking in the throat, we are not able to swallow. Regurgitation, increase the swallowing attempts. Tightness. Now whenever they say tightness, what I say, for example, I removed the partial pharyngectomy I have done along, the mucosa was less. Say for example, my shirt size is 44, if I wear a 35, what will happen? It will tight. Like that I explain and tell him. So we are not able to understand their problem. If they say continuously, if they say, shall I put a rice tube? No sir, I'm drinking water. Somehow they will, really their problem will be there. Maybe we are not understanding. As a surgeon, having so many workload, we try to send him, chalo, you drink water or soft diet they will be taking. This is how we, not giving much importance their complaints and the symptoms comes. What are the changes observed in swallowing post-operatively after the laryngectomy? Is because there is a reduced peak mid-pharyngeal pressure. You see the video fluoroscopy and exam with high resolution manometry. Reduced peak mid-pharyngeal pressures, lower pharyngeal contractile pressure because there is no muscles. All muscles we are removed because of the tumor infiltration, and increased pharyngeal bolus pressure in the neopharynx. So there is a reduced oral preparation phase, especially in patients whose surgery is extended, including thinning of the root of the tongue, or in patients after radiotherapy. Or there is the extension of duration of the palatopharyngeal closure, which results in slower pressure increase at this level. Whenever the tumor is extended toward the base of the tongue, the lowering of the retraction movement occurring because of the lingual pumping. So what happens? The lower peristaltic wave from the pharynx, there is due to the reduction in the pressure necessary for the bolus transit. So pharyngeal muscle contraction will be reduced. The lack of elevation of the pharyngoid complex happens because of the kind of surgery, the resection part involved, and of course, tracheocutaneous fistula also causes the dysphagia. So in this article, he says the narrowing of the pharyngoesophageal segment is about 15 to 19%. A pseudodiverticulum can form whenever you do vertical closure, and cricopharyngeal spasm because when you are not done the myotomy, the spasm can happen, and of course tumor recurrence. These are the causes for the dysphagia. So primary closure provides a better swallowing outcome compared to a flap reconstruction. And a mucosa to mucosa along with muscle, if you adjust and do the preclosure, that will be better than doing a mucosa to mucosa alone. So Larissa, she has in her article, she says the strictures developed in about 19% of the patients, majority are occurred in first year itself. The incidence of stricture formation was similar both in the primary, either primary settings or in the salvage setting. Patients undergoing salvage laryngectomy were 2 times more likely to be reconstructed with a full flap, whereas those undergoing primary laryngectomy, they can be closed primarily. The tubed flap reconstruction significantly increases the incidence of stricture formation compared to the primary closure. The patients who require single dilatation had a better outcome rather than multiple dilatations. So what we do when they come with a dysphagia, we refer to some other center, go for a dilatation. Because if your endoscope is not working, so you have to send. Sometimes in government sector, if the endoscope goes out of order, then it will take minimum months and years to get either replaced or repaired. So I'm not very confident of sending these patients to some other center for a dilatation. But there is no difference in overall disease-free survival in this salvage or in the primary setting. So reconstruction technique, either you do it primary closure or tissue transfer. The dysphagia is the same, and in this article. So prolonged pharyngeal propulsion and increased obstruction at the pharyngoesophageal junction are the main causes of dysphagia in Zhang et al. Paper. This leads to patient-related complaints such as foot staccato, throat, regurgitation, tightness, and longer meal time. So what are the challenges we face after laryngectomy, either in the ward or post-operatively? Whenever there is a pharyngocutaneous fistula or leak through the PMMC, or presence of leak through TAP, TP or periprosthetic or central leak, or stenosis of the neopharynx. This is a challenge. How to manage all these things? It's a challenge. The same, the incidence, how the dysphagia causes spreads across to the extent of recurrence. So most of the stenosis happens within one year, first year itself. So what are the suture material you use? So earlier we used to use a chromic catgut during 2004, 5, 6 those days. Chromic catgut was suture what we were using those days. Leak rates are very high. Then we shift on to Vicryl. Now we use the PDS. The PDS gives very good suture material that reduces the leak rate as well as the other complications. So this is a picture showing a stenosis here, and that side it is a stricture. And the impaired pharyngeal propulsion causes a residue in a fees examination. So how do you treat stoma leak observed during a digestion? This is the picture showing there is a leak. So leak-related issues leads to difficulty or inability to take food orally. So TP leak always we say we want to change the TP, either central or periprosthetic. Either you put a washer or we go for ask for a change, because the process is not free in our hospital. So whenever we counsel the patient for processes, we always say, if you got enough money is there enough to replace her after 1 year, 2 years, if there is any problem happens, then only we put a process. Otherwise, we do not recommend. So this is the leaks. You see intraprosthetic or central leak, the periprosthetic leak. So how do you manage this TP leak? So as I said, you have to go for a change. So how do you diagnose this? So we have to the dysphagia. How do you diagnose the protocols? You have to go for the history taking, the questionnaires, the swallowing assessment with the fees or video fluoroscopy or manometer examinations. So with history taking, this is a eating assessment tool from 0 to 10. So in this, if it is more than 3, is abnormal. So difficulty swallowing. Then sickness swallowing questionnaire, we have about 17 in that. Difficulty swallowing, assessing the quality of life associated with the swallowing disorders. And dysphagia handicap index is about again. Then MD Anderson dysphagia inventory. Some 20 is bad and 100 is the best. So go with the video fluoroscopy. It is a modified, barium examination. Then fiber optic endoscopic evaluation of the swallowing. But unfortunately, we do not have in our center some speech at swallowing people. They bring it once in a week, and they are helping us. Maybe in the future we may get some instruments. So multi-frequency manometry is about assessing the oral and pharyngeal and partial esophageal phase of swallowing. The presence of pharyngeal pseudodiverticulum and narrowing of P segment can be assessed very well, and it is the gold standard in the diagnosis of esophageal phase of the swallowing. This is a picture showing the video fluoroscopy. There is a cricopharyngeal spasm with the retention of food residue in the hypopharynx and in the penetration of contrast into the tissues of the neck. And this is again one more video fluoroscopy showing narrowing of the pharyngoesophageal segment, status of post-laryngectomy, and here in the pharyngeal pseudo-diverticulum in the examination. So what are the surgical techniques we can improve this dysphagia? So surgical techniques like widening of the lumen of the upper esophageal sphincter by balloon endoscopy, either laser or with dilatation, cricopharyngeal myotomy, and placement of stents at the site of narrowing, or laser removal of the pharyngeal pseudo-diverticulum and pharyngeal plexus neurectomy can be tried. Then what are the other conservative technique? Injection of botulinum toxin into the cricopharyngeal muscle. Maybe it is very expensive for our patient, maybe it is 15 to 20,000 rupees, and the benefit is 10 to 60%, but still some patients they try to go for this, where the manometry indicates a decreased relaxation and contraction of the cricopharyngeal muscle. The procedure may be proved effective after injection of the botulinum toxin. So coming to the other exercises, what we can try in these patients. So shaker exercise you can try, Asako maneuver, effortful swallowing are the maneuvers and exercises commonly used in the dysphagia rehabilitation. So these exercises aim to improve the swallowing functions, improve the bolus perfusion, improve the swallow muscle strength, and improve the overall swallowing efficiency. So this is how the shakers maneuver. Then when the patient is lying down flat, ask them to lift the head and until you can see his toes. So keep this size for about and repeat it for 30 times in 3 sets. This will improve the muscles of the back as well as the suprahead muscles and lateral pterygoid muscles. Strength will be decreased. So in the Mazako maneuver, stick your tongue out and gently bite the tip of the tongue. So while still biting, ask them to swallow the saliva. So you repeat it 30 times, and this also helps. And the chin tuck against resistance. This is strengthening the muscles of the back. In a sitting position, put a small ball under the chin and press the chin down against the ball and repeat it 30 times. This is the patient-to-patient communication, how the patient can, seeing at the other laryngectomy patient who is swallowing, you can improve the, confidence level in there, to swallow. This has worked very well. Swallowing problems were much more severe in patient educated high school level and above others. The quality of life swallowing disorders questionnaire scores were significantly higher. So this communication, routine communication group, patient communication group, and physician communication group, the patient communication group has really done well. This is showing the post-operative quality of life in these patients. Again, this graph showing the better in the patient group. So coming to the how we can do a total partial recovery swallowing by tube feeding or oral feeding station, compensatory postural modifications, sensory awareness, placement of food into the oral cavity, feeding appliances, and as I said, the Mendelssohn's and Shakers maneuvers, Mazako maneuvers, effort swallow, multiple swallow techniques. So in this article, they have tried to explain. There is a clinical phase 2 trial with exercise aid, swallowing exercise aid. So trial for the first. This trial was done in 2015. Later on, 20 has been coming in 2019. So this is the aid, with the chest pad, chin bar, chin pad, resistance adjacent to the knob and handle. So this is how the starting position. And the next one is the bottom where jaw opening against the resistance. That is chin tuck against resistance and the effortful swallow against the resistance with 50% maximum range of motion. So the Kirsten et al. Found that CTRA exercise, that chin tuck against resistance, activates the suprahead muscles, infrahead muscles, and sternocleidomastoid muscle. And jaw opening against resistance exercise activating the lateral pterygoid muscle and suprahead muscles. And effort to swallow against resistance exercise activates the lateral pterygoids and suprahead muscles and infrahead muscles. And this is monitored during the MRI assessment. So dysphagia significantly impacts the quality of life, impairing the swallowing. The subjective dysphagia parameters, swallowing capacity and pharyngeal, but BMR, the body mass index, normal. Muscle tongue strengths were within normal range according to this study. So swallowing capacity from 2.4 GS to 3.8 and pharyngeal residue clearance improved. RT2 in the MRI results were slightly lower than the T1, still better than the baseline. So in this article, there is the percutaneous chemical myotomy using botulinum toxin. So they have done, the purpose of the study was to evaluate the outcome of the use of percutaneous injection botulinum toxin under local anesthesia in management of cricopharyngeal dysphagia in post-laryngectomy patients. The 15 post-laryngectomy patients, 6 male and 9 female patients. This neurotoxin was injected after local infiltration. 8 patients, 87% of the patients noticed some improvement in their dysphagia. 1 patient reported an adverse reaction of pain at the site of injection. This is a picture showing the 100 mouse units of botulinum toxin in a 2 ml of normal saline was injected using the 21 kg needle at the cricopharyngeal spar. This is video fluoroscopy mid-swallow image before botulinum toxin and injection is illustrating impaired contrast the medium flow. So percutaneous local injection of botulinum toxin is a simple, safe, cost-effective means of improving the cricopharyngeal dysphagia in post-laryngectomy patients when general anesthesia is contraindicated according to this paper. So the Aris et al. Is to assess the efficacy of radiologically guided balloon dilatation for the treatment of dysphagia secondary to neopharyngeal strictures in patients who have undergone laryngectomy. So 5 patients gained relief, 9 patients required more than 1 dilatation, 2 patients had a balloon dilatation procedure and stent insertion. 3 patients failed to maintain any swallowing improvement. No patient suffered any significant complication. Radiologically guided balloon dilatation is minimally invasive and safe, so it is well tolerated. So it may be repeated frequently and can successfully relieve the pharyngeal strictures in patients who have undergone total laryngectomy and pharyngeal laryngectomy. So Carolina inner paper, so anterior neopharyngeal diverticulum, an outpoaching of the neopharyngeal balloon. So 12 patients, an anterior neopharyngeal, 8 were underwent endoscopic laser excision and symptoms were subsided with completely patients. So this is a picture showing the anterior neopharyngeal diverticulum. Small size varies from 5 mm to 3 cm. This is my one of the patient video I want to play. ಏನ್ ನಿಮ್ಮ ಹೆಸರು? ಎಷ್ಟು ದಿವಸ ಆಯ್ತು ಆಪರೇಷನ್ ಆಗಿ? 2 ವರ್ಷ. ಕರೆಕ್ಟ್. ಈಗ ಆ 2 ವರ್ಷದಿಂದ ಅದೇ ಬಟನ್ ಅಲ್ಲಿ ಇದ್ದೀರಾ? ಮಾತಾಡಕ್ಕೆಲ್ಲ ಏನ್ ತೊಂದ್ರೆ ಇಲ್ವಾ? ಊಟ ಮಾಡಕ್ಕೆ ಎಲ್ಲ ಮಾಡ್ತಿದ್ದೀರಿ? ಮಾಡೋದೇ ಇಲ್ಲ. ಮಾತಾಡಕ್ಕೆ ಏನ್ ತೊಂದ್ರೆ ಇಲ್ಲ? ಓಕೆ ಓಕೆ, ವೆರಿ ಗುಡ್. ಆಗತ್ತೆ. ಸೊ ಎಲ್ಲ ಕ್ಲೀನ್ ಆಗಿ ಇಟ್ಕೊಂಡ್ರೇನೆ ವೆರಿ ಗುಡ್. ಸೊ ಈ ಸೇಸ್ ಇಟ್ಸ್ so he says it is difficult to swallow the ragi ball. So what is, you have to mix with some water and curd so that you can swallow. So coming to my conclusion, dysphagia following total laryngectomy represents significant challenge, not only for the patients, for us also. It is due to either anatomical or functional changes in pharynx and esophageal structures or post-surgery Addressing the dysphagia involves a multidisciplinary approach where both surgeons as well as speech and swallowing therapists as well as dietary modifications. So management strategies are crucial in improving the swallowing function and ensuring the adequate nutrition and hydration. So being a surgeon, I have done maybe around 800 to 1000 laryngectomies I might have done. So in a year we do around 180 to 200 laryngectomies we do in our center. So maybe we are lacking of the post-op, this rehabilitation, swallowing or speech. We have all our patients like that, from the village side, they will come, they are not affordable for processes. And they cannot go to any other center for dilatation or botulinum toxin or anything. So whatever is there, we try to convince them and we keep them with us and we try to help them. Thank you.
Thank you, sir.